Welcome to the Just Ingredients podcast. I'm Cara Lynn, and here we talk all things nourishing to the mind, body, and soul. This is a place where you can find just good ingredients to life. This podcast is sponsored by Llama Naturals. I learned about Llama Naturals a few months ago, and I honestly wish someone had told me about them sooner. I always recommend that people get their vitamins from whole food sources, not synthetics. But I could never find a good option for my kids until I found Llama Naturals. They have a full line of delicious gummies that are made with real fruit, no added sugar or sweeteners, plus vitamins from whole foods. They are USDA organic, vegan, gluten-free, and allergen-free. Plus, they are seriously delicious. You can save 20% off your first order by going to llamanaturals.com and using the coupon code JUST, J-U-S-T. My whole family loves them, but if you have a picky eater, they offer a money-back guarantee. Seriously, you should at least go to their site and compare their label against any other gummy brand out there. They are the best I've found. Again, it's llamaнаturals.com. A diplomat of the American College of Obstetrics and Gynecology, Dr. Suzanne Gilberg-Lenz, received her medical degree in 1996 from the USC School of Medicine and completed her residency in Obstetrics and Gynecology at Cedars-Sinai Medical Center. Dr. Gilberg-Lenz is involved in women's empowerment and public education and appears frequently as an expert in women's health and integrative medicine on TV, in print, and online. She completed her clinical Ayurvedic specialist degree at California College of Ayurveda in 2010 and was board certified in integrative and holistic medicine in 2008. Dr. Gilberg-Lenz has appeared on Today, CNN, Headline News, the Steve Harvey Morning Show, and the Dr. Oz Show. Dr. Gilberg-Lenz is co-founder of Cedars-Sinai Medical Center's Green Committee and is deeply committed to the promotion of healing that involves individuals, families, communities, and the planet. Welcome back to the show, everyone. Today, I am really excited for our guest because she is going to tell us all things about hormones and menopause, and I know a lot of you listeners have some of these questions, and so I'm really excited to talk to her today. So thank you, Dr. Gilberg-Lenz, for being here today.
Thanks for having me.
Will you first start by telling our listeners just a little bit about yourself and your background?
Yeah, absolutely. So I'm an MD. I'm a medical doctor. I'm board certified in obstetrics and gynecology, which means I did a residency for 4 years in OBGYN and women's health. I'm also board certified in integrative and holistic medicine, and I'm trained in Ayurveda. I'm a clinical Ayurvedic specialist, which means that I trained in the ancient medicinal system of India. I think most people are familiar with acupuncture and Chinese medicine. This is the Indian system, Ayurveda. So I do practice in a fully conventional setting in Beverly Hills. I was trained at Cedars-Sinai Medical Center. I'm still on attending staff there. I work with residents and midwives and colleagues and see patients still full-time in my office, full spectrum mostly at this point. But I do have this background that affords me sort of a different perspective and a wider and deeper toolkit. Additionally, I'm a member of the North American Menopause Society, and my focus obviously in the recent past and presently has been in menopause and in the menopausal transition. So we'll talk more. I mean, I don't want to go on and on with my bio. It's not that interesting.
Oh, well, it is. You're definitely an expert. That is for sure. And so that's why we've brought you on today. So let's just start at the very beginning and the very basics, because I want to talk about menopause. If you haven't known listeners, that's what I want to ask her about. Right. So why don't you tell my listeners what menopause really is?
That is such a great question. And I always try to start with that definition because I do find that the terminology is kind of bandied about, and then people really don't know what is going on, what they're talking about, what we're talking about. So menopause has a very, very clear medical explanation. Now, I want to place a caveat there, though. It's not a medical issue per se. It's not a disease. And I really want to emphasize that. I talk a lot about that in general, and in the book, I talk about it. It's not a pathology. It's not a disease. It's a developmental physiologic stage. So that framework is extremely important. Having said that, the definition from the medical perspective is it's one day of your life. It's when you get to 12 complete months without any menstrual bleed over the age of 45 in a person who doesn't have a medical reason that might have caused that to happen, like hysterectomy, you don't have a uterus anymore, or you had an ablation, the lining of your uterus was destroyed, or you had cancer or chemotherapy, or you actually have some other medical issue like thyroid disorder that might be causing the abnormality. So we have to exclude those other abnormalities. But like I like to tell my patients, if you come into my office at around the age of 50 and you haven't had a period for a year, if it walks like a duck and it quacks like a duck, it's probably a duck, not a zebra. That is a medical aphorism. We use that one all the time.
Okay, well, that's good to know. So this is what I'm curious, though, about. How do women know if they're nearing menopause?
It's a great question, and it's a very difficult question for people to grapple with, because a lot of it is, like I said, clinically based. And I think people are getting a lot of information that is questionable. And I will just jump right into this whole hormone testing thing. There isn't a test right now that's available commercially that's going to tell you or predict when you will go into menopause. Now, there are some tests out there that might help predict. They're not widely available, or they're widely available, but they're not widely in use at this point. And I think that's because the data is emergent. And also I think because in medicine, we respond slowly to information. We don't make radical shifts in how we deal with things clinically without a lot of data. And some of that's great and some conservative in a good way, and some of it's not. That test is the anti-Mullerian hormone test. People may know about that because it's used in the context of in vitro fertilization, specifically in fertility. And a lot of people are using it now to predict fertility, which is actually not what it's designed for or validated for scientifically. But it turns out in some of the very large trials, notably something called the STRAW trial, that you can probably predict within a couple of years, so this is not, who is going to go into menopause based on anti-Mullerian hormone. And what that's looking at is it's a proxy for what we call ovarian reserve. It has to do with ovarian function, which is, of course, what causes menopause. In menopause, what's happening is you are no longer releasing eggs, you are no longer ovulating, and you are no longer fertile. This is not a value judgment. I'm not saying anything cultural. This is just like a biologic fact. So I'm answering in a very long-winded, roundabout way, but there isn't a way to know. The way to know is you're in the age group and you're experiencing changes, which I'm sure you're going to want to talk about, that are fairly widespread, somewhat predictable, actually predictable in their unpredictability. And it's a clinical issue. It's an issue to address because A, you want to be in the present moment in the most comfortable way that you can. And B, in order to look at how to age in the most healthy way. So what are the lifestyle changes? What are the medical issues that you may face going forward? And if we know that you're heading in that direction, we can help create more health for you today and for tomorrow. That to me is the main reason people should be focusing. I think if people look at this as an expiration date, I really would love for them to reframe that. I think that's an unfortunate narrative that we've been fed, and we don't have to own that narrative. We don't expire until we actually expire, Right.
Okay, so you just talked about changes. So changes occur before menopause, correct? In that perimenopause timeframe?
Yes.
So what are some of those changes that people could look for during perimenopause?
Yeah. One of the earliest signs that we see in a lot of people, and here's the thing that's interesting, Caroline, like there are certain things that are, like I said, they're predictable in their unpredictability. That doesn't mean that everybody is going to have the same experience, and that doesn't mean that everybody's going to have the same symptoms. But the issues that we see in large majority of people, like probably about 2/3, will see changes in their menstrual cycle. Again, this isn't someone who's having a menstrual cycle. What if you have an IUD? What if you're on the pill? I mean, that's a whole podcast in and of itself. And it's actually really important to discuss because not everybody's coming into this with the same experience. But if you are menstruating on a regular basis, you will probably notice that your cycle changes. In other words, perhaps it will get the periods, the bleeding will get closer together. The intervals will get shorter. the bleeding quality may change. A lot of women will start to experience much heavier bleeding. Then you get into skipping more often, and until you finally are just not having a period. And I can't tell you how many people come in at 4 months or 6 months and thinks it's it, and it's not it. They get a period again. So bleeding pattern changing is a big one. I think the classic hot flash, or what we call vasomotor symptoms, night sweats, all these are kind of categorized together. Those are pretty prominent for a lot of people. And early on, people may notice that they're getting a big change in their premenstrual situation. For some people, it is premenstrual syndrome. In other words, it's really bothersome to them. They may start to have those hot flashes at night in the 4, 5, 6 days before their period. Or they may notice that they have really intense mood symptoms leading up to their cycle, where maybe they didn't notice anything at all, or it was 1 or 2 days. Maybe now it's from ovulation until they bleed for 10 days or 14 days, or I noted that you might have a very irregular cycle. What if you have a 70-day cycle and you're feeling like you're PMSing for 40 days? I hear that one a lot. And in particular, I'll hear new onset anxiety and panic, which I think is really important. It has a very different quality. And I think this is where people often kind of get misdiagnosed as having a mood disorder. And whether or not you're treating it that way, I think is really up to you, as long as the context is provided. You know what I'm saying?
Interesting.
Joint pain, frozen shoulder is like a classic perimenopausal joint issue. But joint pain in general, weight changes, metabolism changes, lower metabolism, easier to gain weight, gaining weight in the midsection. Some of the less common things that people may know about are weird, like dry eyes, dry mouth, burning mouth, vaginal dryness, and sexual changes. I mean, I could go on. I'm making it sound really great, right?
Exactly. I was like, oh, this does not sound fun at all.
Well, it's not fun if you're not prepared and if you don't have a team or support to help you get through it. It isn't fun at all if you're left on your own. And we would never do this with a 10-year-old who's about to enter puberty. We don't do that to 10. That's cruel.
Right.
But that's what we've been doing with women. So We're changing that by having the conversation.
Exactly. Okay. Obviously, all these things are happening because of hormonal changes. So what hormone changes are occurring during that perimenopause time?
I mean, a lot. This is where I wish I had a graphic, right? So maybe some of you remember from middle school health class, that graph of the menstrual cycle. And just so you know, when your gynecologist calls it the menstrual cycle, we're talking about the whole thing, not just when you bleed. So there's usually a very predictable, while you're in your reproductive years, when you're menstruating, there's a relatively predictable experience. You start to develop, people need to understand that their brain and their ovaries and their uterus are talking. I mean, I'm really simplifying it here. But your brain is signaling to your ovary, okay, hey, let's pick an egg to release so that we can get pregnant. And the hormones work in concert. There's a lot of them. There's estrogen, there's progesterone, there's testosterone, there's the brain hormones, follicle stimulating hormone, luteinizing hormone. They are working to select one area, what's going to develop a follicle. That's where the egg is going to be released from. It gets big enough, it releases, you ovulate. Now, progesterone is produced in the ovary. When you don't conceive, all of those levels go down and you release the lining that you have been building up with estrogen in the first half of the cycle. So roughly speaking, estrogen is very important in the first half, progesterone coming from the ovary itself in the second half. As you start to get into your middle years, there's a derangement of that relationship. People are not talking to each other in the same way that they were, hormones. And things start to change, which is why your cycle changes, why you may or may not ovulate, why you may ovulate earlier or later in the cycle. And after ovulation, you may not be producing the same amount of progesterone. So I can't say to you, and I think this is where people really get into trouble out there when they want to test their hormones. What are you testing? This stuff is varying all day, every day. There are circadian rhythms, there are cyclic rhythms, and then there are rhythms that are now in transition. I think when we start calling it balance versus imbalance, that's also putting a value judgment on it. This is not abnormal. If you're 32, this is abnormal. If you are 47, this is normal. This isn't a balance issue. It's a change in the relationship and the ratios of these hormones that are causing these symptoms. So we can dig in a little further. Bleeding issues tend to be because you may be producing more estrogen than progesterone. Now, what's interesting about this is that we know that estrogen is declining during this time of your life, but it's again the ratios of estrogen to progesterone that cause an elevation relative to progesterone of the estrogen. You're producing more lining of your uterus, you're going to bleed more heavily or bleed irregularly and spot. On the other hand, the second half of the cycle would have been dominated by progesterone after you ovulate. And when we see declining levels of progesterone, that probably is contributing to the mood stuff that we feel, the anxiety, the panic. So it's all about the relationships. When we look at, for instance, people all of a sudden get acne again. They haven't had acne since they were a teenager, or maybe they never had acne. And it's clearly hormonal acne, right? It's that, like chin kind of thing around the nose, that stuff. That's because the predominant hormone in women is testosterone. We make more testosterone in our younger years than any other hormone. We don't make as much as men, but we make more testosterone than estrogen. Well, the testosterone will decline in your middle years as well. But if estrogen is falling faster and further, now you have more testosterone. Now you have stimulation of the glands in your face. Now you have more acne. So you can see, I could go on and on, but it's all about relationship and proportions.
So interesting. So I'm going to ask you some specifics about some of these symptoms you just talked about. But I'm curious, are these symptoms mainly during perimenopause, or after menopause, do you experience these as well?
Great question. I mean, I think that the worst symptoms for people are in that perimenopausal period, which, by the way, peri is just the Latin term for around. So I make the joke all the time. If you're a menopause expert, everything is perimenopause, right? So, because that's a really ill-defined term as well. And people, they also feel like it's like, oh, you just you pointed me out. I'm shamed. You just told me I'm in perimenopause. I mean, I would love for people to hear that a little bit differently. But having said that, peri could be 2 to 10 years. I mean, it could be longer. It's that transitional time. That I find is when people really have the hardest time, because of the unpredictability, especially if you are very keyed into your cycle. I had a patient yesterday who is 48, and she said it so clearly and so beautifully to me. She said, I have been so body literate. I have worked so hard in my life to be body literate, and I have no idea what's going on now. And she was really having a hard time, not only with the symptoms, but this loss of this feeling of control. Because she thought, oh, I know who I am. This is who I am this 7 days of the month. This is who I am this 14 days of the month. Oh my God, who am I? I'm not that person anymore. So it's deep, right? It's not just the symptoms people feel, it's the response to the change in the symptoms. I find that to be the most difficult time. Once people are in the menopause, so they have passed that 12 months and they're either menopausal or postmenopausal, whatever you want to call it, it's a lot easier. There are symptoms that can persist though, Carol Ann. And so those things can be bothersome to a lot of people. The hot flashing can continue for quite some time for a lot of people. And then the ongoing loss of estrogen specifically can continue to be an issue for people in terms of joint pain, loss of muscle mass, weight and metabolism, sleep, and also the longer term issues with sexual function, urinary tract issues, vaginal dryness. And then health consequences, heart disease, osteoporosis, dementia, and Alzheimer's. I say these things again, not to scare people, but to help them locate some agency in all of this. If they know that these things are going to become an issue, they can anticipate strategies to manage and diminish those risks. Yeah, that's what's important to me.
Right. I agree. Okay, so let's clear up something for the listeners, because menopause is the one day after 12 months of no bleeding.
Yeah.
But a lot of people will say in their 50s, 60s, oh, I'm in menopause, so I'm having hot flashes. But really, they're not in menopause, they're in postmenopause, correct?
If they're totally done, they're postmenopausal, or you could call it the menopause phase. Here's the thing. I'm not here to argue with people about words. I just want them to, because I feel like, especially as an expert and as a physician, I mean, my job is to help people get through this, and I consider myself a healer. And it's not healing to be like, you're using the words wrong. I mean, that's ridiculous. That's why I also use terms like bioidentical hormones. I mean, is that a medical term? I mean, technically it's not. But do your audiences, do people understand that term? Yeah, they do. So I use it because my job is to be a bridge and to speak the language. So I think you're right. I think people are using the term loosely, and it's interesting because to me, when I hear people say menopause, I think they mean more the transitional time. I don't know. I guess what the great idea here is to ask, what do you mean by that? Like, what's going on with you?
Right.
That to me, for me, that's what I do for a living, is to help understand where you're coming from so I can meet you there and then help you get to where you want to be. I mean, it's really not that complicated.
Right. I just wanted to clarify it because some women don't know the exact differences. So I just wanted to clarify that. But now, because you are a healer, that's actually what I want to talk to you about. Some of these common things that you hear about in menopause, hot flashes. So you touched on it a little bit, but are there natural ways or ways to help women that are dealing with hot flashes?
Yeah, there are. I mean, the gold standard, honestly, the most effective way to manage hot flashes is with hormone therapy. And we can dig into that when you're ready. But there are, I think, some good natural remedies out there because I am trained in Ayurvedic herbalism and I understand botanical medicine. I'm really a big fan. And I'm a breast cancer survivor. So my choice has been to not use hormones in that way because of my particular medical issues. Having said that, you can never, the data that is pharma derived is just way more robust. There's way larger numbers involved in studying effects and efficacy and all that stuff than there's ever going to be in a botanical study. But so I'm always very clear about that. I want people to understand, you can't put black cohosh head to head with estrogen. It's just not possible. But black cohosh is actually one of the herbs that I do think has decent data to support its use. One of my newer favorites is something called French marine pine bark, also known as pycnogenol. I really like that one a lot. What we call phytoestrogens, which are molecules that behave somewhat like estrogen that are directly from the plant world. So I think people probably know something about red clover or the soy-based products. Those can be decent. They're not as great, but they can really reduce and diminish the impact. So if you're looking at, a 50% reduction in hot flashes in a person who's hot flashing all night, I mean, that can be a game changer. And a lot of people will choose to start with those and really see a real big benefit. I will say this, it's really, really important to be very careful about the source of your plant medicine. Just because something is on Amazon doesn't mean it's good, doesn't mean it's safe, doesn't mean it even has what it says it has. I'm very clear about product safety and vendors that I like, and people can go to my website and see all that information or buy the book. I'm very, very, very clear about that.
That's so good. I am too. And so I think my listeners will understand that I talk about it with CBD quite often, that there's a huge difference between the ones on the market, and don't just grab something off Amazon because you're not quite sure of the sourcing, things like that. So I love that. Okay. With hot flashes, I once heard that if you're low in magnesium, that could be a root cause of hot flashes. Is that true?
Magnesium and B complex can definitely help. I mean, I think, to be perfectly honest, look, if you have nutritional deficits, which a lot of us do, and I think what happens is we end up in a more vulnerable position when we're in a transition, whereas maybe you got away with some nutritional deficits that you weren't even aware of. Now you're vulnerable. You're gonna really start feeling them. That might be helpful to you. I think it's probably not going to be enough for somebody who's really having a lot of hot flashes. And some of the other, vitamin E has been looked at, some of the omega-3s. The data's okay, it's not great. It's not going to hurt you, but it's probably not going to be enough.
Okay, good to know. Let's talk about decreased libido. So why does this happen? And are there ways to improve these symptoms?
Yeah, I mean, this is such a big one. First of all, libido is not an on-off switch. It is not yes, no. It's complicated. There absolutely is. As our hormones are declining, our drive towards sex definitely declines. And we do know that testosterone does play a role in that, but it's also multifactorial. So I touched on the fact that estrogen decline will contribute to changes in the vaginal tissue, for instance. If you have dryness and pain with sex, if you are not having the same kind of orgasm or an orgasm anymore, you're not going to really want to have sex. If it hurts, why would you want to have it? There's other things. There's social factors. Do you have a partner? Do you like your partner? Have you been with your partner forever? Is it kind of boring? Is it stressful? Or do you have, older adult relatives that you're caring for and kids in the house? Is work crazy? Did you just go through a pandemic for 3 years? We can't really say it's all perimenopause and menopause, but it contributes. And I'll tell you that I think one of the biggest factors is not addressing the tissue changes, and also, the very unsexy activity of having to, in a long-term relationship, make it a priority. It's not like you see the person down the hall and, you're wet. Okay. Like that's you, great, amazing. But for a lot of people, that's not what's happening anymore. And you need to communicate with your partner. You need to have a conversation about needs and changing needs. And you need to commit to it and say, Thursday night is our night or Sunday afternoon is our time. And what we know is that when people have an activity that they enjoy, they will be more motivated to do it. And it changes brain chemistry. You have dopamine, you have serotonin, you have anticipation, which will actually assist and help in the process. So it's 100% fixable. I mean, there's so many things we can do. Whether it's vaginal hormones, which, by the way, are safe for people who can't or don't want to have systemic absorption. They don't want the hormones throughout their body, but they want it vaginally. It's totally safe. That can be helpful. Pelvic floor physical therapy and sexual health practices like sex therapy can be very helpful for pain. And also there are devices, energy-based devices, a lot of which we've borrowed from cosmetic surgery and from aesthetics, that can help replace and replenish collagen, elastin, and help to regenerate healthy, youngish tissue in the area, which can help with dryness and function. There's so much to be done.
Interesting. Okay, so the vaginal hormones, are those bioidentical hormones?
Well, I mean, all different kinds exist. Pharma and FDA do make bioidentical approved substances. So bioidentical, let's talk about that definition. As I mentioned, it's really a marketing term, but what it means is the chemical is biologically identical to what your body was making in larger amounts before you got to this place in life. That's all it means. And by the way, these are all chemicals. I had a conversation yet again with a patient yesterday, but she didn't want chemicals. And I was like, okay, I hear you. You understand that, like, actually that coffee in your cup is a chemical. So people are understandably, I know what they mean. They want natural. The natural hormones are, I'm going to take your ovary, which I'm not doing. That's murder. Like, you did not consent to that. So it's not natural or not natural. It's synthesized. It's produced in a manufacturing plant to look, behave, and act exactly the way your hormones that you were making were. So that's what bioidentical is. Bioidentical is available by prescription, made by pharma, FDA approved. You can pick it up at your pharmacy that your doctor prescribes to. So that's really, really important to understand. I stick with the bioidenticals. I like them better. I think the data is stronger. I think they are safer. That doesn't mean there's no risk involved in any of this. But the vaginal hormones, most of them, not all of them, are bioidentical.
Okay, yeah. That's good to know. So are there other things besides the vaginal hormones and all those other things that you talked about that could help with libido, such as herbs or different foods, nutrients?
Yeah, the nutrient thing, I got to tell you, I don't have any really good, clear data on nutrients really having that, other than I think some of this is like body image stuff too. So if you're feeling funky in your body, and we didn't talk about sleep, if you're not sleeping well, I mean, your head hits the pillow, you don't want to have sex, you want to try to sleep. So, we didn't even talk about sleep is like a whole 5 podcast series right there. So nutrients, not so much for libido, but other than to support other bodily processes. The data on herbs, not so great. I think maca is okay. I think maca is pretty good. That's probably the best one for libido because it can have some testosterone-like impact, basically. And a lot of people who use the other botanicals to support their process, again, I think probably because they're feeling better in their body, then they feel more in touch with their sexuality. I don't think, I can't prove any of that, but I think that's probably more what the connection is.
That makes sense. Okay, you just were talking about sleep, so let's move on to that topic because sleep does become an issue for those in perimenopause, menopause. And so why is that, and how can we help them?
Sleep is so difficult and elusive. And I will tell you, it is the topic that when I was working on the book, I was like, I just don't have the answer. Like, I've been doing this for 22 years and I still don't know what to tell people, and I hate to tell you that I did not find the answers. I mean, I think it's complicated. Some of it is definitely related to other menopause symptoms. So especially hot flushing. So if people are not realizing that they're waking up because of hot flushing, the hot flushing has got to be dealt with. That's one of the big ones. But all humans as they age have more interrupted sleep. So if you have a man in your life that is sleeping in the same room as you, you probably are noticing that he's getting up to pee all the time too. Some of it is melatonin decrease. Our own melatonin that we produce decreases over time. Some of it is disruption of melatonin and sleep cycles and circadian rhythms because of our lifestyle, because of our devices, sleep hygiene, which every single person I talk to about sleep hygiene knows exactly what it is. And 90% of them are just not doing it.
Yep.
I mean, that's within our reach. I myself I am also the same person. I do that too. Vasopressin, which is a hormone that is responsible for literally helping us to not go to the bathroom at night, starts to decline as well, which is one of the reasons why we have to get up and pee. So it's complicated. And I will tell you that I think sleep hygiene and changing our nighttime behavior in general, including our eating and our drinking, is one of the most important things we can do. Having a nighttime relaxation ritual. And when I say drinking, I don't want people to restrict fluid intake, because that actually doesn't work and it's not necessarily so good for you. But alcohol specifically, alcohol at nighttime is just, you're not going to sleep. You're going to wake up. And also stopping eating, a good 2 to 4 hours before you go to bed really does help. It helps with metabolism and it actually helps with sleep, because some of what's going on may be related to insulin and glucose cycles while we're sleeping. Some people will be waking because they are having changes in their glucose, their sugar, and that's waking them up too. So some of this is something you can hack yourself, and some of it is stuff you really probably need to be talking to your doctor about. The other thing is sleep apnea. People, who are snorers, maybe having sleep apnea. I can go on and on and on. I do think, you mentioned cannabis-based products. I'm a fan, for the right person, of a good cannabis-based product. But I think people need to understand that the way they consume it is very important. So an edible or a gummy might be better because you're going to get a bigger release 3-4 hours in, which may help you continue to stay asleep. Because most of what I hear is waking up, not falling asleep.
Right.
Falling asleep is okay. It's waking up. And if you vape or smoke, it's more immediate and it may not last you. Same thing with tinctures, anything that you're getting right under the tongue and getting into your system immediately. That's a little bit of the Wild West. I don't think anybody has proven that sleep is really going to be better based on using CBN or CBG. We get really in the weeds with this one, but I didn't mean to say that, but that's funny. But I'm interested in it. I'm really interested in how that might be useful for people.
Right. Well, and I know they're doing a lot of research with those CBN, things like that, but sleep is a complex issue. Like you said, there's so many different underlying root causes for people, and it can all be different for each person.
Exactly.
So that is tricky. Okay, let's talk about another symptom, though, of perimenopause and menopause. What about weight gain and muscle loss? I know this is one women complain about all the time. So is there some way to help this?
Oh, yeah, definitely. And it's real. It's really real. I think a very large study came out sometime during the last couple of years that was really, it was problematic. They looked at, it was a large population-based study, and they looked at weight gain and aging, and they decided, oh, it's not true. Women don't gain more weight in menopause. And it was like, okay, listen, folks, what are you even talking about? The reality is that we don't have to gain weight, but we're going to have to change our lifestyle in order to do it. Will the weight distribution change? Yes, it will. It will. The loss of your waistline is actually a real thing. Hormone therapy may assist with it. It's not going to fix it. You're alive in your body. Your body's going to change. That is how it goes. As we age, we lose muscle mass. Women and men do. Men, maybe a little bit less than women, but a lot of that is linked to declining levels of testosterone that we talked about. But it's also, again, it's lifestyle based. So if you are a person, if you're addicted to your Peloton, awesome. That's so good for your cardiac. health, but you need weight bearing. And women in particular need weight bearing and resistance training in order to build that lean body mass, to build the muscles, to build the bone strength, because we're also losing a lot of bone strength. And that's very, very important. And I think people really looking at their diet and adding more protein in, high quality protein, is super important. You're not going to build muscles without high quality protein. The other thing that's really interesting, though, and this is another large study that came out probably in the last couple of months, last 6 months maybe, and it looked at basically overtraining. And anybody who's in this age group and works with this age group knows this. You are much more prone to injury. We're not as flexible as we used to be. We really have to work at active recovery, stretching, things like that. So if you are someone who wants to go hardcore and go at it, you're actually not benefiting yourself. You are increasing inflammation, you're increasing stress on your body, which is going to make you hang on to weight. And you're going to hurt yourself. Right. So the sweet spot seems to be twice a week, really good resistance work, weights, whatever, something like that. That's muscle building, and 2 times a week cardio, not more. I mean, you do it, do you? But this study it was really interesting. It looked at people in their 60s. And they found, women in their 60s, they found that the people they compared 1 day a week of each, 2 day a week of each activity, 3 day a week of each activity. In terms of muscle building, I found this really fascinating. Really no differences, which I was shocked by. But in terms of weight management, the people in the middle did the best with weight management. So you got to get up and move.
That's interesting. Well, I know there's some women that don't move at all, but then there are some women who love to work out 6-7 days a week because it's good also for their mental health.
Totally. And I don't want people to stop doing that, but I want them to be cognizant of what they're doing and how they're doing it. I think variety is the key, but constant look at fitness or exercise is the number 1, 2, and 3 thing that you can and should be doing for yourself today and for the rest of your life. You're getting the blood flowing. You're, like I said, increasing your lean body mass, including your bone mass. You're getting blood flowing to your brain, to your heart, to your genitals. Your mood is elevated because of the feel-good hormones that are released. I mean, I could go on and on and on and on. You make different choices in terms of how you eat and when you eat. Your sleep is probably going to be improved. So there's every study in the world shows that all of your lifetime risk factors are completely altered by exercising, but it's also just like common sense,
Right.
Like, do we need a study to prove that?
Right. Okay. So this weight gain and this muscle loss is mainly coming because of the loss of testosterone.
Don't quote me on this because I'm not a fitness expert. I'm an OBGYN, but my understanding that is a very big contributing factor. Probably how we're metabolizing is changing as well.
Okay. Good to know. Previously in the podcast, you had mentioned that depression, anxiety, that those can be symptoms of menopause. Yeah. So let's talk about that. Why is that?
Well, I mean, I think like every answer is it's multifactorial. I think some of it we discussed was especially in perimenopause, we see this big jump in like anxiety, panic kind of PMS symptoms. And that is pretty clearly linked to changes, declining levels of progesterone. We are pretty clear on that. I think it's probably also other pressures, issues, lack of sleep. We know that any human who doesn't sleep and get good quality sleep is going to have more mood disorders. So this is sort of adding to it. And then I think just sort of the pressure of our modern lives is creating more opportunity for mood disorders. But I think there may be a gift in it as well. I mean, I don't want to like paint too rosy a picture or be like a proponent of toxic positivity, but difficult challenges and passages can be growth opportunities. And what I see a lot in midlife is people reassessing their life, reassessing their relationships, reassessing how they spend their time. And sometimes what comes out is frustration. If you look at the cultural expectations on women that are very gendered, and that we are really starting to look at and unpack and disassemble, they are that we are caregivers to everybody except ourselves, that we are supposed to martyr ourselves, that we're doing everything for everybody, running around like maniacs, that's not sustainable. And we can yammer about this, but a lot of people have to hit the wall themselves and feel it. And they have to make decisions that include their own prioritization. They have to decide that they matter and they count too. Sometimes that's just a very privileged position. There are people who really don't have choices, don't feel like they have choices, are working multiple jobs to try to keep themselves and their family afloat. But I think even just acknowledging that and understanding how damaging that can be and how much that contributes to mental health issues, if we don't say it out loud, I think we're really doing ourselves a disservice. And I think it's something that at least coming together as a community is really addressing and really helping, because when you have other people that you can talk to about this and you're not isolating or feeling ashamed, you will have a different perspective and you'll have a larger pool of resources available to you.
Right. That's really good info to think about. So if women are feeling mood disorders while they're going through menopause, do you have certain herbs, certain supplements?
Yeah, I do. I'll tell you, my favorite is vaydik or chasteberry. It does a lot of things. And here's the other thing. I always want to be careful with when I talk about botanicals and having respect for the entire plant, because a lot of times we want to use these plants as a substitute for pharmaceuticals. And sometimes they do work really well, but they are not pharmaceuticals. They are plants. So there's something called the entourage effect. We don't understand every little molecule and how it's interacting with themselves and with us when we consume them. We do know that there's probably some component in the plant that helps our ovaries produce more progesterone in the second half of the cycle. And so that's probably helping with some of the PMS mood symptoms. It helps with other breast tenderness and other things that people tend to get with PMS. I love it for this. And I've seen it really work very well. I myself used it. But plants are a little bit different than obviously a lot bit different than meds. We're not taking one compound and purifying the heck out of it and then amplifying its effect. So people should consider that when they're using things. It also will take longer for them to affect. I tell my patients who are using plant medicines or botanicals to give it 60 to 90 days, where, Prozac may take 7 to 10 days. Vaydik is probably going to take you 2 or 3 cycles to notice a difference. That's my hands down favorite for the perimenopausal PMS. There are reams of data out there on all sorts of other, rhodiola, ashwagandha, St. John's wort. There's lots of data on sort of things that have an impact on mood, but I tend to reach for the Vaydik the most.
Okay, that's really good to know. So I'm curious, going into perimenopause or menopause, are there ways that we can help balance our hormones so that it's an easier transition?
That's a great question. And like I said earlier, I think we need to sort of stop thinking about this in terms of balance and imbalance, because again, this is more, I like to see it as a transition, which is what it is. I think, first of all, letting go of this idea that we are going to control it is very, very, very important. And I know that's maybe not what people want to hear, but sorry, that's what I have to say. When we want to micromanage it and we think, oh, I'm going to buy these 5 herbs and I'm going to fix it and I'm not going to feel anything, and that's just not real. So this transition occurs for a reason. We don't understand all the reasons that it occurs, but it occurs. And I think having that attitude, and then, like I said, having a good team and having a good community is actually more important than any particular hack that I'm going to offer you. If you can enter into this time of your life anticipating some of the things that we've talked about, and now we've talked about some of the potential solutions, you're not heading into it and blindsided and have no idea where to go for help. Now we have podcasts like yours, we have community, we have my book, there's the online menopause community is exploding. There's a lot of resources out there. Coming into it with an eye on fitness, movement, sleep, diet, the basics these are the most powerful tools you will have in your toolkit. And then you can, as needed, dip into the plant medicine. into the holistic traditions, if that is something you like to do, into the hormone therapy, if that's available to you. And also understanding that it's going to change. It's not going to be like one and done. You're going to go to the doctor, you're going to get a script, and you're going to be, no. I see my patients regularly every 3 to 6 months because I know this may be working for this quarter and next season it's not going to work anymore. We got to move on to the next thing. So having that flexibility is very, very, very important too.
I love all of that. Okay, so you mentioned, though, the hormone therapy, I should say, and I have listeners, followers who ask about this all the time. So let's just touch upon this. Are bioidentical hormones a good thing during menopause?
Yeah, I think they're great. I mean, we talked about it. I think they're highly effective. And again, I want to remind people that bioidentical hormones are not necessarily something that you had to go and get tested 40 times this year and go spend a lot of cash money that you may or may not have. And that the doctor has their own compounding pharmacy in their office. I mean, that is not when you and I are talking about bioidentical hormones, that's not what I'm endorsing. I'm going to leave that alone. I don't personally think that's the best way to do this. Bioidentical hormones, again, are hormones that are available commercially that are biologically identical to what your body has been making. And you can find safe, effective, well-studied options in that area at your doctor's office with a prescription. That's a thing.
I mean, you talked about them not testing. So how do you know if you need progesterone or estrogen or testosterone?
Such a great question. And I'm going to blow your mind clinically by talking to you and listening to your story and your complaints. I'm not saying that I never test. I mean, if somebody comes in and there's something that's raising a red flag, or let's say you come in and you're on testosterone, I may want to watch your testosterone levels because testosterone levels can be too high. Testosterone can cause problems. It can cause not only side effects like acne, hair loss, but, in very high amounts, people feel amazing on them, but they also can be causing, heart disease, and they can convert to estrogen and cause abnormalities in the lining of your uterus. Again, testosterone is amazing, but these things are powerful. And the people you work with who you are getting these from, really, you should make sure you're vetting them. Like, just because your best friend's sister told you to go and she's got a pellet in her butt doesn't necessarily mean that it's the right way to go. Check it out. Make sure you see what their training is. Or is this a person who did a weekend course and used to be an anesthesiologist? I mean, I'm sorry. I'm just going to say these things. This is what's out there.
Right.
The North American Menopause Society, which I love and I'm a member of, but I don't think is perfect. I'm probably a little bit of a cowboy. There are, I think, about 2,000 of us. There are, I believe, 40,000 fellows of the American College of OBGYN or the American board certified OBGYNs. And I'm not saying that you have to go to an OBGYN who is trained through North American Menopause Society, but that gives you an idea of how few of us really have very good formal training. That's not to say that people out there who are outside of that community can't be excellent at what they do, but please buyer beware. So yeah, I'm not a fan of people testing. I think you need to understand and they need to understand why they're testing. I was taught real old school at USC LA County Hospital many moons ago by real docs who put their hands on the patient, okay? And it was ingrained in me. If you do a test, what are you doing with that lab result? Now, if someone is using it to tweak, and you're coming back every 3 months to change your dosages, why? That's not individualized therapy. That's, I'm trying to get you into this reference range, which, by the way, they made up. There are no reference ranges for optimal sexual health in a postmenopausal woman. Show me the study. It doesn't exist. So I really want people to be very careful and intentional. It is mind-blowing, but we are treating you as the human with your clinical symptoms because it's not a disease. It's a stage of life. How do you want to feel? What are your goals? What are your priorities? What are your health risks? What do you need? That's what I'm looking at.
So there are a lot of women that don't feel well during this time of life. And so can they just go to their OBGYN and their OBGYN's going to know how to best help them, or not necessarily? They need to be trained in this.
I think that they should, if they have a good relationship with their OBGYN, they should start there, because if they have a relationship, then they can have a conversation. And that person may or may not feel like this is really their wheelhouse. They may start them on some pretty standard fare that is not super well thought out, but like the sort of standard of care. And this person may or may not have a lot of training and may not be that adept and may not be that nuanced at it. That doesn't mean they can't do it. I think it's a very hard time for women in a lot of ways, because what's happening, you're really hitting on something so important, Carolyn. We're all starting to talk about it now. And then well, where do we go? Because if you look at TikTok or Instagram, it's confusing. And there's a lot of this, your doctor doesn't know what they're doing. I mean, your doctor may or may not know. That's absolutely true. But most doctors are pretty high integrity and will say, this isn't my thing, but so-and-so does it. Or you can take it into your own hands and you can go to the physician locator on the North American Menopause Society, homepage, menopause.org, and do some due diligence. The other thing is that not everybody can afford to do this. Not everybody has insurance even. And I'll tell you that insurance often doesn't pay for the medications that I think are the best ones. It's very frustrating. This is what I do. Yes. So I'm adept at it and I'm willing to work. And I think more of my colleagues than people might realize are out there willing to do this. But it is true. People need to be very, very savvy consumers, and they do need to advocate for themselves.
Yeah, I agree with that. Definitely. I'm glad you explained all of that. As we wrap up here, will you just tell my listeners where they can learn more from you and where they can find your book?
Oh, yes. Well, they can find me all over the socials. My handles pretty much everywhere are at Ask Dr. Suzanne, AskDrSuzanne. Just look my name up. Or go to my website, thedrsuzanne.com. There is a link to purchase the book, but it's widely available. It's published by HarperCollins, so it's, bookshop.org and Amazon and Kindle and all of that. And there's a really lively community out there. We're really having a conversation. The engagement has been tremendous. My book, Menopause Boot Camp, was developed out of a menopause boot camp that I run. And those are going to be up and running periodically. But the cool thing is that I'm actually creating a certification program so that people can come and learn how to run their own boot camps. Because I feel, Carol Ann, that this is something that people need to be doing on their own in their own community in a way that serves their community's needs. I can give you the basics and I can give you the template and I can give you what information has worked and a format. But I think for me to think I'm going to go into your hometown and I'm going to understand what people need there is, kind of arrogant. And I do see this as a grassroots movement. I've seen it in other areas, in obstetrics and prenatal care and in childbirth. We've seen a revolution because people took hold of it and said, hey, this isn't working for me. This isn't what I want or need. And I need you to respond to what I need. And I need you to explain yourself to me. We need to have a conversation about this. And when people from the grassroots came into community hospitals and asked for more and asked for better, they got it. I love my colleagues. I love my organizations. I respect and appreciate them. But to think this is going to be a top-down change, I think is naive. And we know that we deserve more and deserve better. And people like you who are willing to have this conversation and educate your community are so important in this conversation, so important in helping us care for ourselves, So I want to thank you.
Well, thank you. And thank you for everything that you're doing and trying to educate people on, because this is an important topic. Menopause is going to happen. You can't escape it. And so we need to be more educated as to things that we can do to better help ourselves. So thank you for what you're doing. And on that note, do you have one last bit of advice to these women as to what to do to best prepare for menopause?
I think, just don't be afraid to say the word. Don't fall into the stigma of it and whisper or shut it out because you're afraid or you feel like it's some kind of a pejorative. I think the most powerful thing we can do is, like I said, change the narrative and not accept a narrative that is not our own. I think that's probably just good life advice.
Right. Well, thank you so much for being here today. I know the listeners have learned a lot, and I'm excited for them to go find your boot camps and your book and things like that. I always end my podcast with asking my guests what they have found to be the best ingredient in life. What would you say it is?
Oh, I think, the best ingredient in life for me is to be where I am, to be present where I am, even if it's uncomfortable, because that's really all we have.
That is true. Well, that's a really good one. Something to think about for sure. Well, thank you again for being here. Like I said, I know my listeners have learned a ton, so thank you for taking the time.
Oh, thank you so much for taking the time and having me. I really, really appreciate it.
Thank you so much for listening. Remember to subscribe to the Just Ingredients podcast to learn more about your health and good ingredients to life. Plus, get daily tips at just.ingredients on Instagram.